Welcome to another edition of Cancer Facts with Dr. B. Today's question is, when does prostate cancer become clinically significant? It is the point at which we have scientific evidence that we can reduce the chance of developing metastatic prostate cancer by at least 1% with treatment compared to no treatment after 12 years. Let us look at a diagram to help us get a sense of clinically significant prostate cancer and aggressive prostate cancer. I've made a diagram and it's broken into 10 different areas. Area 1 is where we would consider it a precancerous lesion, previously what we would call a Gleason score of 2 to 5, whereas Area 10 is where the cancer has spread throughout the body and has become resistant to most forms of treatment. So if you were in Area 10, you would have less than a 1% chance of surviving 10 years with aggressive treatment. However, if you were in Area 2, you would have less than a 1% chance of dying from your prostate cancer with or without treatment. So when is treatment recommended? In a large trial from Johns Hopkins, they recommended treatment when the cancer no longer fit the very low risk definition in younger men. The very low risk definition included clinically T1 disease, T1C disease, that's when you cannot feel it on a digital rectal exam, a PSA density of less than 0.15, grade group 1 disease only, 2 or fewer positive biopsy cores, and a maximum of 50% involvement of any biopsy core with cancer. However, on the NCCN guidelines, active surveillance is an option for both low risk and for favorable intermediate risk disease. So looking back at the previous slide, one observation is that a tumor that has a Capra score of 3 can fit into areas 4 through 7. In other words, say a group of men are considered to have very high risk prostate cancer using the NCCN criteria. This group could also be made up of guys with a Capra score of 3, making the results look better than if the Capra scoring was used. So looking at this system, we can see on this bottom part of the arrow, it represents what's the chance of dying from prostate cancer with aggressive treatment. If you were in Area 5 and you received aggressive treatment, you would have a 2% chance of dying from your prostate cancer. If you were in Area 2, you would have a less than a 1% chance of dying from prostate cancer, and that's likely with or without treatment. Whereas if again you were in Area 10, you'd have about a 1% chance of living with prostate cancer after 10 years. Looking at the top part of this slide, we can see that in Area 4, the chance of developing metastatic cancer goes from 5 to 15% if you're on observation, which is a little different than active surveillance. This is from the PIVOT trial where men were divided into prostatectomies or close observation. Approximately 20% of the men that were in the observation group decided to get treatment. But what we found was that after 12 years, within Area 4, 5 to 15% of the men without treatment developed metastatic disease. So for some institutions, their trigger for saying that a cancer is clinically significant is when the cancer goes from Area 2 to Area 3. Other institutions on their active surveillance protocols will watch men in Area 3, and there are still some active surveillance protocols where men will be placed on active surveillance even if they're in Area 4. This is typically for men who have a short life expectancy because of other risk factors like cardiovascular disease or diabetes. As doctors, we should be able to clearly communicate how aggressive your cancer is using that diagram. The way we do this is a stepwise process. Step 1, we look at your risk factors that we know about before treatment. Your grade group or your Gleason score, how many biopsy cores are positive, your PSA level and maybe your density, your age, and what your clinical stage is based on the T, N, and M system. Again, that's looking at the tumor, the nodal status, and the metastasis status. And for some newer prognostic stratification systems, they're even using a genetic profile. Step 2 is where we ask, what's the endpoint that we're interested in? So for example, number one is biochemical relapse-free survival, PSA control, or biochemical control. They're all the same thing. You would really want to know, once you've had one treatment, say a prostatectomy, you could find out what's the chance that the cancer will come back after that prostatectomy based on the PSA. So with a prostatectomy, your PSA should go to 0.0. If it starts to rise, that means that there's cancer somewhere in your body, and then you have to consider a second line of treatment. The next would be, what's the chance of developing metastatic prostate cancer? Because again, a rising PSA really doesn't affect your quality of life other than anxiety, but metastasis can, and certainly if the metastasis is causing pain, like it can when it spreads to the bones. Fourth, we can consider the prostate cancer specific survival, or what's the chance of dying from prostate cancer. And fifth, what's the overall survival with treatment A versus treatment B. So the next step is which stratification system we're going to use. This first stratification system, the SCORE, which is a proposed system, is based on men treated at different types of institutions, both academic and community. Also men treated in the United States, Canada, and in Europe. And it can answer the question, what's the chance of dying from prostate cancer 10 and 15 years down the road after, say, surgery or conventional radiation therapy. The Memorial Sloan Kettering nomogram is specific for men who undergo prostatectomies at Memorial Sloan Kettering, which is one of the largest cancer centers in the world. Typically at an academic center, the surgeons are only performing oncologic surgeries, and for some, they may only be doing prostatectomies. So their skill set may be better than a doctor who treats everything at a community hospital. But the Memorial Sloan Kettering nomogram can give you PSA control. It can also give you prostate cancer specific survival data. The Capra score is also based on patients treated at academic centers as well as community-based centers. And it can give you the PSA control, the metastasis-free survival, and the prostate cancer-specific survival. The NCCN is a commonly used stratification system, but as we talked about before, it may not be as accurate as the Memorial Sloan Kettering nomogram or the Capra score. So after we've come up with our endpoint in which stratification system, we can go back to our diagram. Say we have a guy who has a Capra score of 2. We then know that we can place him in area 2. And in area 2, we know that we are very good at pursuing active surveillance with a very low risk of him developing metastatic disease 10 to 12 years down the road. Also, we can tell with that Capra score that if he were to have a prostatectomy, he would have a 20% chance that his PSA would go up after surgery. Again, I think this diagram is useful for patients to determine what's clinically significant prostate cancer and what's aggressive prostate cancer. You want to think of your cancer as being in one of these areas or on one of these points on this arrow, where a Capra score of 2 or area 2 really doesn't need treatment and can be placed on an active surveillance protocol, whereas every doctor would recommend treatment if you were in area 5, which we would call unfavorable intermediate risk cancer, or have a Capra score of 6. Again, knowing what your Capra score is, you can determine your PSA control with surgery, you can determine your prostate cancer specific survival, and you can determine your metastasis-free survival with surgery based on a cohort of men that were treated at both academic centers and community-based centers. Thank you.